Thank you for the kind introduction. I'm Hiroyuki KAMEDA from the Department of Radiology at Hokkaido University Hospital, Japan. Today, I'd like to present my work on MR imaging of neurofluid in humans using O17 water. Here is today's outline. First, I'll introduce neurofluid and CSF tracer imaging, although this may somewhat overlap with previous presentation. Next, I'll discuss the basics of MR imaging using O17 water, and lastly, share data from ongoing clinical studies showing the potential of O17 MRI for neurofluid imaging and discuss its future prospect. Regarding the lymphatic system, Dr. Kato provided a detailed explanation. In this concept, CSF enters the brain through the perivascular spaces located in the arteria on the brain surface, then circulates through the brain parenchyma, and finally leaves the brain through the perivenular spaces. And so, such CSF dynamics is thought to function as a brain clearance system and to be involved in the pathogenesis of various brain disease, including Alzheimer's disease. So neurofluid is the term introduced to define all fluid in the brain, like blood, CSF, and interstitial fluid. And the neurofluid imaging is the recent main topics in neuroradiology because assessing neurofluid dynamics or the lymphatic function could be a novel imaging biomarker. To visualize such CSF dynamics, many researchers in experimental biology inject a fluorescent protein into the CSF as a water tracer. This method is good, but it's not ideal for human use because of its invasiveness. In contrast, clinical MRI is non-invasive and used proton for imaging, which makes it an excellent choice for live neurofluid imaging in humans. One of the strategies to study CSF dynamics in MRI is using CSF tracers. In a recent study, researchers tried to visualize neurofluid by injecting a gadolinium tracer intrathecally. This approach effectively demonstrated the flow of neurofluid from the surface of the brain into the brain parenchyma. But intrathecal injection of a gadolinium agent may have certain side effects. In addition, it may not truly represent neurofluid dynamics due to the difference in molecular weight between solute and water. So the use of water tracer for MRI is also important. So let's look at the potential water tracers that can theoretically be available with MRI. In my opinion, there are 4 tracers, O15, deuterium, and O17 labeled water. In addition, magnetically labeled water, which is used in arterial spin labeling, can also be categorized as endogenous water tracer. Of these, we have focused on O17 water because unlike short-lived tracers such as O15 and magnetically labeled water, O17 water allows us to follow water dynamics over a long term. O17 is the only stable isotope of oxygen that can be detected by MRI. Because of its stability, there is no radiation exposure, making it safe for human administration as either water or gas. Natural abundance is low, so it can be used as an exogenous tracer. For MRI detection using O17 water, there are 2 methods, direct and indirect method. Direct method requires specialized equipment for O17 NMR. In contrast, the indirect approach uses the teeth shortening effect of O17 water in clinical proton MRI. Because of this advantage, we take the indirect approach to our research. In this slideshow, you can see phantom images of O17 water scanned by clinical MRI. We can observe the corresponding decrease in T2 value as the concentration changes. So O17 water is a negative contrast agent in T2 weighted images in clinical MRI. In addition, we can dynamically visualize the O17 water using fast MR sequences. In the preclinical case, I present here a model of arterial infusion in rodent. Heavy water infusion can be detected as a signal decreasing lesion due to the reduction in proton content. In contrast, O17 water as a tissue shortening contrast agent can be detected as such in signal reduction on T2 weighted images. Both are stable isotope labeled tracers suitable for long-term direct water imaging with MRI, but we believe that O17 water may be more preferable for use in the human because of fewer biological effects than deuterium water. The development of O17 water for clinical use in cerebral blood flow was conducted by Professor Kudo of Hokkaido University. He is a pioneer in this field, also my mentor. Completed physician-led clinical trials have shown that intravenous administration of O17 saline is safe and allows for O17 concentration-dependent imaging of CBF. This is the data from our clinical trial. After venously administration of O17 water, we observed the spread of O17 through the cerebral cortex via the perfusion. Additionally, rapid leakage of O17 water was observed in the CSF region, such as the subarachnoid space and ventricle. Interestingly, the leakage into the subarachnoid space was found to be faster than into the ventricle. Such an observation challenges the conventional understanding of the CSF production, which assumes that the CSF originates from the choroidal plexus within the ventricle. This finding suggests the need to reconstruct CSF circulation and highlights the potential of O17 MRI to redefine intracranial fluid dynamics. Based on our experience with O17 MRI, we explored the applicability of O17 water as an intrathecal CSF tracer. I think the feasibility of imaging potential in rodent neurofluid has been shown by our group, Dr. Kato, Dr. Kinota, and our collaborator, Dr. Komaki, and Dr. Obata. So the aim of our study was to assess the feasibility of imaging neurofluid in humans using O17 water and MRI, and to evaluate its effectiveness. We are currently conducting clinical trials using O17 water injected intrathecally for MRI. We are focusing on patients with normal pressure hydrocephalus or dementia. During the CSF examination, we administered 10% of O17 water intrathecally and followed by obtaining 4 brain-related weighted images at 4 different time points, which is a baseline, and after 8-24 hours of administration. So the O17 concentration was calculated using the described formula, which determined O17 concentration depending on the signal decrease from the baseline. In the T2 weighted images, we generated O17 concentration map for each time point like this. To date, 10 patients have completed this study with no adverse event reported. In terms of the efficacy, we have been able to follow CSF dynamics, CSF turnover using this method. The interim results suggest that the clearance of O17 water was slower in the INPH group compared to the other dementia groups. I showed 2 patients regarding the infiltration of O17 water from the CSF space into the brain. This patient finally diagnosed with Alzheimer's disease. In the O17 concentration map, the O17 was prominent in the basilar system intermediately after administration, which gradually decreased. The brain parenchyma showed a similar pattern, although with uneven distribution across the region. Patient 2 indicates a very mild cognitive decline and no specific clinical diagnosis was given. In the O17 concentration map, the O17 peaked in the bilateral cerebellum barrier 1 hour after administration and then declined. Although we currently have data from only a few patients, we observed that patients with relatively observed cognitive function have a more pronounced distribution of O17 water within the brain. This indicates the potential of O17 MRI to assess the lymphatic function in humans. Abnormalities in neurofluid, which is thought to be the brain's clearance system, may occur before morphological changes in the brain. So the O17 intracerebral technique may be effective biomarker in early detection of Alzheimer's disease. Finally, I'd like to discuss the challenges and the future prospects. First, there is a need to improve accuracy of the O17 measurement. We currently use the weighted image-based approach. Signal values in weighted images can vary due to various factors such as MR setting, patient's movement and artifact, and so on. To solve this, we need to adapt quantitative MRI imaging such as T2 and T1 low maps. We are developing fast and high resolution T2 mapping. And in addition, validation with a direct method is also required. Secondly, it is necessary to perform neurofluid modeling using O17 water distribution data and verify the lymphatic system. Thirdly, this has been already shown by Professor Watanabe. Thirdly, the spread of CSF tracer among individuals may significantly vary. This is understandable because of CSF dynamics are influenced by various physiological parameters. So we need to verify the variation in the distribution of O17 water administered into the CSF in humans. Additionally, several promising MR techniques for evaluating neurofluid, especially non-invasive method, has been proposed. As this technique can be repeated, so we need to verify how the accuracy of disease diagnosis changes when compared or combined with these techniques. Finally, MRI has limitation in obtaining micro-level information. Therefore, validation using micro-scale imaging tool is necessary to discuss the mechanism of neurofluid dynamics. To do this, we are collaborating with Dr. Sakamoto. He's an expert on isotope microscope system, a unique imaging device owned by Hokkaido University. We aimed to observe the micro distribution of water, so he modified the system to allow cryo observation of tissues. This is a preliminary result, but the micro-level distribution of water traces can be observed consistently in the vascular lumen of rat tissue. So using O17 water as a common key tool, we are working to reveal neurofluid dynamics in the multi-scale. So this is my conclusion. In summary, we are attempting to assess lymphatic function by visualizing CSF dynamics using O17 water in intrathecal MRI. The interim results show the feasibility of this approach. Thank you for your attention.